Very big thank you for our panelists for being here today. It's amazing how many hats people wear. So within just this group of 4 people, we've got so many perspectives represented from clinical in terms of being a clinician, a patient, people who are part of a community group, have lived experience, are involved in funding research, are involved in have been involved in the policy side of research. And to get going, I'll just introduce everybody and then we'll ask some questions. So Dr Anae Neru Leavasa is a specialist GP and clinical director for the Cause Collective. With extensive experience in primary healthcare and policy as a former Member of Parliament, he plays a key role in shaping equitable health strategies for Pacific communities in South Auckland. Supporting the Cause's practice network team, which works with 44 clinics and over 140,000 enrolled patients, Dr Anae champions systems change, workforce development, and improvements in health outcomes using innovative health solutions in the communities he serves. And towards the end, Dr Natalie Gauld is a research advisor and best practice advocate at Motor Neurone Disease New Zealand. She is a pharmacist and researcher with honorary roles in the Department of Paediatrics and the School of Pharmacy at the University of Auckland. Natalie is passionate about improving access to medicines and optimising patient-centred care, and has extensive experience in healthcare innovation, implementation and evaluation. She was diagnosed with motor neuron disease, or ALS, in March 2022. Greer Pugh is a first-year PhD student in Human Cardiorespiratory Physiology Research Group at the University of Auckland. Her research focuses on postural orthostatic tachycardia syndrome, or POTS, a misunderstood condition that primarily affects young women. As both researcher and patient, Greer is uniquely positioned to bridge the gap between the scientific and patient communities. Her lived experience with POTS drives her passion for understanding its underlying mechanisms, improving patient outcomes, advocating for awareness, education, and better symptom management strategies. Rich Easton is the CEO of the Neurological Foundation and chair of the Neurological Alliance, an advocacy group comprising 20 charities working together to get better outcomes from government and the health sector for those of people affected by neurological conditions. Rich has a business background in technology and customer care, along with previous experience in positions leading the board of trustees of the First Foundation, Make-A-Wish Pacific Islands, and volunteering Auckland. So a pretty impressive lineup, I think you'll agree. So I think I'll just begin by kind of introductions from our panelists themselves, their kind of roles and their current focuses. So Dr Anae, can you tell us a bit about the Cause Collective and your role at the Cause Collective?
Thank you. More level for time being also to the Reverend. So a couple of minutes to us, so thank you. Very as well. So the Cause Collective, so I'm the clinical director for the Cause Collective. So not only I look after the primary health organisation that sits under the Cause Collective organisation, there's also other programs that we run. So many services. There's 3 goals that we have in mind, which is number 1 is community health. So that's where the care trust sits under. Health coaches, health improvement practitioners, and so forth. Our second goal is all about intergenerational wealth. So financial literacy for our youth, employment, training for our youth. And then our third focus is on self-identity, cultural traditional values. So that's where we engage with, we have about 20 churches that we engage with, where we visit 40,000 membership, really congregations. So we find that it's not only the health that we try to look after under a Pacific model, it's the whole wraparound services that we try to give our youth, our families. So that's where I love this position, because I can focus on clinical things, but I love that we can do it working on the outside, on the community side, with kids. I've seen where employment needs, care training needs, working with our families, to see if we can assist with that. So Yeah, so the organization's very big, so over 100, 140 people in staff. We're one of the organizations that won the Fund Order contract as well. So we look at specific things across our table and with our program. So that will launch in July. So yeah, so multiple priorities that the course group has. I'm just glad I've got part of my job.
Thanks very much. And Natalie, tell us about your role at Motor Neurone Disease New Zealand and how you became involved with MND.
I'm only there 10 hours a week, and I became involved after I got MND myself. I did some fundraising, so I got to know them. I went from absolutely the right way. I raised you some money and how I'm using it. And I was really keen as a researcher. I was looking at research papers around MND, so hardly any research being done in New Zealand, and thought, actually we really need to understand what's going on with patients got an HRC research education grant, and then ended up doing some work at MND New Zealand around research and best practice. And we've been working on revamping the research strategy, and so it's been a big focus, and leading a big survey that we've kind of eked out the HRC money, put in a bit extra from MND New Zealand, and they're doing a big survey. So that's helpful.
And Rich, tell us about the Neurological Alliance and your role at the Alliance.
Sure. So the Neurological Alliance is a virtual collaboration of 20 charities that work in the neurospace, some quite large ones, like Alzheimer's, Parkinson's, through to some quite small ones, like Neurone Disease that we were talking about before. And the focus is around getting better outcomes for people living with neurological conditions, both for the individuals themselves and also the support that their family members often develop around that, and we'll talk a little bit more about the priorities later. It's been around 25 years. Probably in the last 5 years, we feel like we've got a bit of a head of steam, rather than being a mutual support group, and actually taking some leads from alliances overseas and looking at the role that we can play as advocates into government and into the health sector as well. We've just, in the last 3 years, as Lisa was talking about in one of her presentations earlier, we've reached out to the Neurological Alliance in the UK and also in Australia. We've got to a very trusted position with government to whenever they want to look at a position on neurological conditions as part of their health strategy planning, they go to their alliances, and particularly the UK has 70 member organisations. So kind of using some of their capabilities, but also using where they've got to as an aspiration to help the 1 in 3 people that are touched by neurological conditions somewhere in their lifetime.
What about your role?
And yeah, so my day job, the CEO of the Neurological Foundations, have been there about 8 years, and as a default from that, that's got me into the Alliance. As Lisa said, I have a business background, and I have a clinical research background. And one of the learning challenges I gave myself was using the Alliance to actually meet all of the other organisations, to get an understanding of what is it, the research that we're funding at the Neurological Foundation, how does that actually show up in the outcomes for people doing university. So the Neurological Foundation itself, we've been around, what's the time, 7 months, but it was 3 or 4 years now. And our focus is funding research into neurological diseases and disorders, and also about education and awareness. And in particular, in the last few years, we've been putting a lot of effort into how do we collaborate more closely together with some of our peer organisations. We're funding research that is of interest to the people living with their conditions. How do we doing those stories together? And so at the moment, we're funding about $5 million of research a year, which is all through New Zealanders' generosity. It's not through government funding. And one of the challenges that I think a few people mentioned this morning is, and the funding landscape for research is really challenging at the moment. So we're doing some work to look at in our strategy where can we best fit some of the opportunities, but also some of the gaps that are at the moment. Very excited. We've got 2 new funding streams that go live this year, a platform of research and a program of research, which paid about $1 million each of them. So something that we haven't done before, but hopefully is a real good opportunity for New Zealand research.
And Rhea, tell us a little bit about POTS. I know not many people will know about POTS and what your research project, your PhD.
Yeah, sure. So POTS stands for postural orthostatic tachycardia syndrome. It's a complex chronic condition of the autonomic nervous system that's characterized by a significant increase in heart rate on standing that's not due to a drop in blood pressure, which has kind of stumped researchers for a while now, because most of the time when patients stand up and they get that dizziness feeling, we've all been there, got up a little bit too quickly out of bed. Imagine that happening every single time you get out of bed in the morning, every time you stand up. So that's what patients with POTS experience on a day-to-day basis. So patients often present with this really fast heart rate, mostly on standing, that's alleviated while lying down, but also symptoms of orthostatic intolerance, or where standing is not tolerated very well, like fatigue and dizziness and this concentration difficulty known as brain fog, and also general symptoms of autonomic dysfunction, where the autonomic nervous system isn't working very well, like gastrointestinal disturbances, this chronic fatigue, migraines. The list goes on. I can sit here all day listing symptoms of POTS. What's interesting about POTS is it often presents with other things as well. So there's something I like to term POTS BL, because there's always more to the story. So deep tissue disorders are more common in people with POTS, autoimmunity is more common, and allergy issues are more common. So these patients do end up being quite complex. So my research is interested in this particular thing that we observe in patients where they stand up, and over the time that they're standing, their feet slowly start to turn a bit purple, and they get this thing known as blood pooling. So they stand up and the blood drops to their feet, and then their heart's having to compensate for that, and work quite hard to bring that blood back up towards the heart and the brain. So my research is wanting to know what the blood vessels are doing in terms of their structure, function, and regulation. So we're looking at things like how stretchy the blood vessels are, because if the blood vessels are too stretchy, then the blood's going to end up staying in the feet. Or if it's more of the nerves aren't communicating with the blood vessels or telling them to squeeze on standing, that helps to push the blood back up towards your heart and your brain. So whether there's something going on there in patients is currently unknown.
Fascinating. I don't know how to measure those
On the complex measures, yeah.
So obviously the focus of this session is about working together to promote positive change. So I guess thinking about the key changes that each of you would like to see in, and I guess we could all come from the health background, in current policy practice. Rich, maybe you could outline some of the, like, what are the key priorities for the Neurological Alliance, and what are the key barriers to achieving the goals of the Alliance?
Yeah, so to that comment earlier about getting a focus, we narrowed down on 4 particular areas. So the first is very much about the challenges in the workforce around access to neurologists and neurospecialists, and in particular, if you live outside of the main centres, the remoteness and the challenges that comes of extra difficulty in travel, especially the hours to go and see a neurologist, for many people really difficult. So trying to raise a lot of awareness, but also recognising that you can't suddenly hire a 10-year neurologist. It takes years to grow somebody with those specialists. So making sure that there's some long-term planning. And the other things are around prevalence, because the number of people living in the conditions is growing. The second is around access to drugs and pharmaceuticals, and it's a huge challenge for many conditions. Some drugs are well approved. There are some great drugs overseas that pharma won't approve in New Zealand yet, have big impacts. So it's about being advocates more consistently about there are things that we should be thinking about bringing to New Zealand, and this is the impact linked to prevalence. The third is in particular the side impacts of the 1 in 3 people impacted somewhere in their life, the impact for their family and their whānau and their care workers about often having to give up their day job to be able to support them. If you've had a debilitating stroke, you can't even get out of bed in the morning. You're needing somebody full-time to help you, and that has a huge impact. And yet, we don't well serve those communities because they've had to give up their whole lifestyle and their income to be able to do something that they haven't planned for. And then I think a huge link to conversation that we've been having today, the last focus area is about prevalence and incidence and just having enough data. So some of the neuro charities have funded and invested in data for their particular condition, but across the board, there's almost no clear data about current state of what Dr. Richard has in hold. And if you look at global numbers with Alzheimer's, Parkinson's, etc., expected to grow hugely in the next 20, 30 years. But is the health system ready to cope with that? And kind of not directly linked to the Alliance, but with my foundation hat on, so we're also starting to do a lot of work around advocacy about investing in funding research as well.
What about you, Dr Anae? What are the current priorities of the Cause Collective? What changes would you like to see, and what's the barriers to those changes?
Yes, yeah, but the 5 big clinical priorities that associated with mental health, and family violence. So those are key areas that we're trying to put a lot of work into. When I guess the barriers for that is because we're clinicians, we've got our networkers and so forth. We're on the ground, but you don't have specific researchers based at our organisation, and that's part of why I'm here. It's just to build relationships with our researchers because we need the important data to obviously inform policy. So at the moment, when it comes to PHOs, we're about 7 PHOs in Northern New Zealand. When it comes to data, we have one central point which to all our houses, where researchers come to get their data from primary care centres. I didn't mention it before discussing it, but this is the current context where researchers get their primary care data from, but that's only within our 7 PHOs up here in the village. So all the clinical directors sign off on research requests. So when you do sign off, researchers grab the data and they don't see it anymore. So that's where we would like for us as an organisation have more of a partnership with the patient, because the data that you're creating, we want to be part of it as well, because that's going to benefit our cohort of patients. So when you go to, we want to go and present the data that you're creating, that we've worked together. So we get multiple research projects. We would love to have a better connection with researchers. So that's where this is all part of that.
And Natalie, what are the current priorities for MND New Zealand?
So NED New Zealand helps with supporting patients. So we've got support advisors and advocacy and best practice. We also have a research side, and I'll just briefly talk about priorities with that. The research, we know our community wants to see a cure, and we're really supportive of the Centre for Brain Research. We've got a unit of 10 people there working on MND research, which is great. So we're keen to help in that regard. So we've got an MND patient registry that they can use for doing their genetic testing and things like that. And we also support them in other ways. And then we really want to influence advocacy. If we have evidence, we can use that for our advocacy. And we also want to get more people interested in MND. People with MND may have 12 or 15 different people they're dealing with, mostly allied health. And in those areas, they're working with a little bit with MND and a lot with other things. So if we can encourage some of those at the coalface to be involved in research projects that then can help improve care and develop health professionals as researchers who can get very knowledgeable about MND and become sort of mentor or guru that other people around New Zealand can go to, that's going to actually really help our patients in the long run. So advocacy and creating evidence and growing interest in the understanding.
And what are the key barriers?
Key barriers, well,
Yeah.
of course, number one has to be money. The
Yeah.
more money we have, the more we can do. So that's great. Second one is that, as I was saying about the health professionals, MND can be a really small part of the role of a physiotherapist or occupational therapist or even a neurologist. So if we can get interest from them in MND through research and knowledge through research, and then go to international conferences around MND, things like that, interact in other ways with international researchers, that's going to help. But that takes a bit to get over, because MND is actually quite unsexy because it's quite fast progressive. So there's sometimes a nihilistic perspective around treating somebody with MND. So those are there's quite a few barriers.
Yeah.
And I'd like the researchers to know more about us and come to us as well.
And Greer, what are the being the last one to speak for all of POP's research, but generally what is it that the POP's community would like research to do for them?
So, like, research priorities, we've got a whole bunch of different areas. We've got those that are looking more at the autoimmune side of things. We've got those that are looking at links between other comorbidities. We've got, like, what I'm doing, looking at mechanisms. But speaking from the POTS community, awareness and recognition is a big thing. Patients often spend years trying to find a diagnosis and get access to care. And that's been quite a barrier with research, is we need people who have a clinical diagnosis of POTS. And there are so many people with POTS who recognise, I think I probably have POTS, and most of the time they're right. But then they get brushed off as having anxiety or overthinking their symptoms or being hypervigilant. POTS more commonly affects females, about 80 to 90% female. And I think that has been quite a big barrier for the community as a whole. And that's where I'm grateful to be in the position that I'm in, as I'm a patient researcher. I have a lot of experience with POTS. I've been through the diagnosis process. So about 5.5 years ago, I got sick with the virus and never fully recovered. It's been a long journey, but now I'm in a position where I've got access to the patient community through Facebook groups, through social networking, and other groups like Ehlers-Danlos Syndrome New Zealand. We don't have a community group specific for POTS or dysautonomia in New Zealand, apart from Facebook groups, but I'm grateful to be part of those Facebook groups, and I can bring the science to the community. And in return, that's where I do a lot of my recruitment. So I would not be able to do the research I do today if I didn't have POTS, if I wasn't engaged with the community, because we would not be able to recruit, because there's limited specialists out there who are willing to see patients, and the ones that are absolutely amazing. And they've been a huge help for our study recruitment, but there's just not many of them. So key barrier, access to care for our community.
I mean, it does sound definitely awareness and education of, or having clinical champions is a key issue for a lot of, especially disorders that affect fewer people. And even like some disorders where that GPs, have so many different conditions to contend with that. Having we read disorders in New Zealand, they do have like a professionals register, I guess, of people that are interested in different things, but everybody is extremely busy. What do you think? What do you guys think about some of the ways we can, as researchers and community groups, could work together to overcome some of the barriers we've talked about?
If I'm offering push to directly to us.
Yeah.
I know there is a central pool for primary care data, but there's only 7 VHAs. Just come to us, especially with specific data or specific VHA. So all our comments, well, most of our policies are directed to specific things, and the data that we want to investigate, that's kind of benefit of so I think it's just a little more discussion.
Yeah. Any other thoughts?
I think also that from a researcher's perspective, having an understanding of the lab condition so that you're not going in just with a researcher's hat on going, oh, I'm all about the observed aspects of it, but you're looking at neurological conditions, often, as you were talking about before, the brain fog or the ability to record things, or if you've got dementia, the ability to actually understand perhaps what somebody's saying or recall the message. So making sure that the research is really understood and put the person in an environment where they can contribute to the research. I think on the awareness side, like the thing I've learned most in the Neurological Foundation is that almost all research needs control groups. And so how do you also then attract people in that aren't living with a condition, maybe are age related, and get them excited so that you get that balance. I learned just years ago, so the dementia prevention research clinics are looking at our normal brain cognition works versus what shows up with dementia or memory loss. But actually, to be able to analyse that, you also need people of kind of my age and above to be in the control group to look at what normal aging is. So how do researchers help encourage people to actually participate to support that both sides of the picture?
Yes, I'm in that same group where I'm trying to recruit people, and I've got quite a lot of interest from the POTS group, which is absolutely amazing to see. But then trying to match the controls, and sometimes we end up with daughter with POTS comes along and mum comes along to the visit. It's like, oh, participators are healthy, and then just like, oh, but I've got a genetic connective tissue disorder. I'm like, okay, so well, that explains the daughter's POTS as well, but we can't have that. But definitely working together collaboratively with patient communities, researchers and clinicians helps a lot with recruitment. Is probably the biggest thing. That then we as researchers, we're the ones that are keeping up to date with the literature. We understand clinicians are busy, they don't have time to read up on all the conditions that they treat. So in the ideal world, we'll be working quite closely with clinicians to be able to inform them on what's going on, and then also feed that information back directly to the patient communities, but bring stories and experiences from the communities back into the research, and that gives us the why. Why are we doing the research? To help the patient communities. Yeah.
With the survey that we've just done with MD patients, we did a lot of work with patients because it's a really big survey and we needed to know how would it work with eye gaze. Were we missing anything that they thought was really important? How did they feel about answering questions, about Twitter, about finances and things like that? What do we do to ensure that we get the information that we need from them that I guess helps them to reflect their experience? So one person told me, for example, that her memory was not very good, and that's not uncommon in MND. And so it was like, okay, so we don't ask a heap of open questions about what the problems are, but we have to be more specific. What was the problem in this area? What was the problem in that area? So the work with the community was really important for ensuring that the questions were not offensive, we proceeded, like toileting, for example, in a way you don't have to answer this if you don't want to, and making sure we knew that they knew we had privacy around it and things like that. But involving us as the community organisation, we had support advisors who had really good input into the survey, who have seen many different patients going through. And so, they had some really helpful ideas about the things that we should be asking. From my end, I was thinking about what do we need to advocate with. So if somebody comes to me with a research proposal that they're wanting to put out, I'd love to be involved early on, because I can say, hey, here's an area where we really need some more evidence. What, when you're asking about this, can you actually add on a little bit about that as well? Because that's going to help us with our advocacy. That's going to help us argue for extra care funds or quicker reappraisals of needs, things like that. And so we can help people get out to the research community. We can help link them with people to trial the questionnaires and things like that. But we can also, if it's done at an early stage, we can also influence some of the questions that would really make the research much more impactful in terms of change, which is what we all want.
It's about that getting people involved from the beginning, isn't it? Rather than turning up, asking for people to do a survey or asking for data without having that initial.
I think ideally you'd have them early, but I tell you, we are so keen for MD research to happen that if they only turn up at the late stage, we'll do what we can with them, and then keep working with them so that we can help them disseminate and so on. So, and it might well be that we can still do a little influence at that point where we say, well, actually it needs to go out in this way, or you need to give it this much time, or whatever. So yeah, we just have to talk to them.
I think another part of, I know we do this with the research when funders in the playback after you've done the research. So how do you take that back to our participants, hopefully in a language that they understand with what we're buying, what are the implications, what might it lead to next, because that further encourages people to participate, but also allows them to understand the value that was brought through the research as well.
Anyone got any further thoughts around that? I was just really interested, I guess, from all of you, when people come and do research at the Course Collective, what are the kinds of things that what are they doing? What research are they?
So the most recent one was about eczema and by trying to find inequities of treatment. So that's, I do a lot of approvals when it comes to stuff. But again, it's that whole connection, like you said, when they present late, but they got a good topic, it's still approved because we want to see that research done. But yes, it's the ideal situation. Move together, be on the waka together.
And what kind of things in terms of MND, Natalie? What research is going on where they're coming to MND New Zealand to?
Well, I was really pleased with one recently where it was a wheelchair survey for people with MND, and the person is a wheelchair seating expert, and she came. She's got a supervisor who's working with her. She's got cold-face experience. She says, "Oh, I'm not a researcher, but actually, that's what we want. We want that cold-face and research combination." And so, we work together. It's out there in the field at the moment, and we're very pleased about that. And then there's another one who we've been talking to recently. He's going for an HRC grant around wheelchairs as well in telehealth, which I think would be a real advantage. So we can see how that would help our community, and then sort of advocate for it with the NHS. So with this.
Do you get a lot of approaches around clinical trials, or is that not?
That's actually a huge thing. I should have mentioned it. Barriers. We don't have. We have one clinical trial running, which the Neurological Foundation co-funded with MND New Zealand, and that's just stopped at an early stage because it wasn't successful. We want more clinical trials. Our survey is showing that, that our people want clinical trials here. So that's something that we're working on, but it's not easy to get them going here. And it's on my really important list. Having the NND patient registry helps with that though, because it gives us an indication of how many people there are who are likely to fill the criteria on where they are. But yeah, it's something that's really important to us.
Yeah, I think in the past, probably 10 years, pharmaceutical companies have slowly withdrawn their staff anyway to Australia. So there are very few pharmaceutical companies that have, you know, people running clinical trials in New Zealand. And it does seem that means now that there's fewer opportunities for New Zealand patients to be involved in I don't know about kind of university initiated clinical trials, but certainly I know from kind of rare disorders, New Zealand's perspective, that is something, especially for rare disorders, we don't see very much of, and people really would like to be taking part in trials, but they're just not.
So part of that is because we've got such small numbers. So if you do a trial in Melbourne versus New Zealand, you know, there's a lot more concentration. So that's helpful, but it also depends on having those key specialists who have that research interest, and that's something that we're trying to encourage as well. We want neurologists to get more interested in research and want to push that.
It's all very interesting and learned. Well, heard about what's for the first time being and to hear it from the audience. Important to know about it. And I just wanted to pick up on the recruitment side and how the course curriculum is approached constantly during the research. I think there's a role of responsibility for the researchers to consider carefully how they're approaching, and I want to speak from a Pacific perspective, Pacific researchers, or the Pacific services, rather, because I know of other social services that are constantly approached for support with recruiting participants into their study. Or giving advice, specific advice on their study, and yet there is they're not engaged to build a relationship, to introduce. It's sent out as an email, and I think a lot of it comes from students who are doing a master's thesis. Some doctoral students, and their supervisors can, because they're senior supervisors, they can play a role in advising the student, taking the time to go request a meeting with the service. Because for Pacific, face-to-face meeting and engagement, and Dr. Anae were very generous in approving the request. And we do, on the whole, we do want the support to the research request, but it comes at a cost because and as you said, yes, they get support with the recruitment, but there's no comeback, not to the courtesy of benefit. And so I think that's important for research to engage with Pacific communities, and they're expected to be taken into Pacific community groups that can have a connection with a person who has a good link with community, because when they take them into the community, they will automatically know that the researcher can be trusted, because the person that's brought them in has strong working relationships with them. And challenges we're facing all the time, and the exciting thing is how to overcome those challenges. Something to person that personal contact is important. And having the introductions. and then build a relationship that can continue, because one piece of research doesn't answer the question. It needs to be built on and ongoing. Yeah.
It makes you a better researcher to have that connection as well than just turning up somewhere, getting the data and skipping off. Nicola,
Thank you. From a cause or an organisation, community organisation perspective, research by its nature is based in the present or the past, with the exception of longitudinal or prevalence studies. So how can we all, as diagnoses or causes or support organisations, project what we know from current research, kind of overlaid with changes in culture and society and technology and ways that people can be supported, receive information and all of that, to ensure that we, in say 5 years, moving forward 5 years, where should we be going? Really interested to hear your comments as to what you think from your cause perspective, how you would use your information to help ensure that we provide strategic planning for different fields and those within the room.
So, just to clarify, you're asking how can we use that research to move forward? Is that what you're saying, or have I missed something?
Yeah, and ensure that we are tracking or moving forward in the direction that is going to be most relevant, meaningful, valid for our community. However that evolves in the next, say, 5 years.
So, I think if the organisation is all organisations should be looking forward anyway. So a part of that is probably getting baseline data and then getting repetition to sort of see if you're tracking in the right direction. So what we've got now with our survey, we really do need to repeat it in the future. We'll be able to put in place some things. We'll be able to say, right, by this date, we would like to see this happening, and then we could re-measure it in the future. So I guess if we're involved in the research at the early stage, then we're using that future vision to say what we want to get and then how it can happen next. And part of the work that we're doing around research with this survey is to try and find areas that then we can get other researchers interested in working on and how to create that change, but then we're about measuring it again. I hope I've answered the question all right.
No, I totally agree. I'm thinking about wider societal factors as well. And
Yeah.
We have digital natives coming through. Everybody changed a lot during COVID.
Yeah, true.
Everything in the wider picture is evolving. So it's kind of hard to, I guess, overlap that with what we know from our own.
And what we're going to expect to happen with AI in the future as well. So we could get some quite different, we might see some really different, much earlier diagnosis being needed, for example, if we've got different biomarkers and AI involved at an early stage. So yeah, you're right, there's lots and lots of changes in the sector.
Thing to add to that, so the talk that Lisa was giving about the beginning of the research for the Neurological Alliance, so that's helping us to build that current state understanding, which allows us to do more of the advocacy work, which allows us to influence public health priorities and spending, which then when we go back in 4 or 5 years' time, we should be able to measure whether our advocacy has been successful or did we miss the boat and do we need to redo it a little bit. So I really hope that learning on what they've done in the UK and what I think they're working on in Australia, that potentially we can leapfrog a little bit in our development as an alliance around the role that we play, to actually be on the front foot for something for the next 2 or 3 governments to start making some more informed decisions. But it's long run.
I think it's very hard sometimes So I'm thinking about TSC again, but this is a condition that affects people from birth. So for us as an organisation, actually what we should be doing is listening to young people about what they want, because nobody who's currently living with TSC is going to benefit from a cure for TSC. So if we want to know how to support people with TSC in 10 years, we need to be asking people who are 10 years old now. But I think it's much more difficult when you have conditions that affect older people. But I think you can still ask, you know, you need to be asking young people, if this was to happen to you in the future, what do you want to see? So that we're keeping focus on what the communities want. But how we do that, I'm not sure. But I think, yeah.
Well, the young people in the family with the older person,
Yes.
you can see, there's a really audience for you because they will see it and ability of the family. So, but yes, you're right with advocacy. It's going to play a key role, including the communities that see the people that are making the decisions around it for the future phenotype need to hear about the local experiences as well as the researchers.
And in terms of what you do at Force Collective, do you have strong links with community, you know, or charity organisations, I guess? How does that work?
I think in our social space, churches, we've still linked and we have a strong connection there. I think with our clinicians, that's how they work. They're just really busy,
Yeah.
you know, head down doing things. So I think when it comes to looking ahead in the future, we'd love to see diabetes and conditions reduce, especially for other Pacific communities. We know, speaking with Dr Wood, they said that bariatric surgery is not going to be the thing more soon. That there will be more looking at medical management. So looking at research for how's that going to work in the medicines that we're going to be using for obesity-related issues. Diabetes, Pacific, you know, I guess everyone doesn't like doing the needle, insulin, you know, on a daily basis. So what are the type of medicines that future is easier, more accessible? And one other thing too, in terms of the clinician side as well, in terms of artificial intelligence, a lot of our time is we're doing a lot of admin work. We're trying to look at our inbox and looking at all the lab results. So AI is playing a huge role there. We're partnering up with the University of Auckland to look at AI Scribe. So I know for over a year now, the technicians are using scribing just talk. The AI is doing all the writing for them for the notes. But one of the things we're doing at the university is translation. Because a lot of us speak, I speak Samoan on my planet. Will the AI be able to write that, you know, and understand it where I'm not making a lot of changes to it? So simply just
So obviously a lot of people have developed POTS after COVID. So I think I was very hopeful that there would be a big change in how POTS is managed in New Zealand. That doesn't seem to have happened. Is that a correct assessment, and why do you think that is?
I think COVID has brought a lot of awareness to POTS. So for those that don't know, there's quite a lot of overlap between POTS and long COVID. So if you were to stand a long COVID patient, likely they have some form of autonomic dysfunction. That's not everyone with long COVID, but a good proportion of people, especially younger females, do present with POTS-like symptoms, if not COVID-induced POTS. That's definitely been a big thing in the literature around research into why this happens, and we've got research going on at the university specifically into long COVID. But from a community point of view, hasn't changed greatly. There's a lot more talk about POTS, like on social media and stuff. And more recently, we've actually run into the problem of POTS becoming a social media trend. And that's something I've heard clinicians say, which is quite frustrating, because once again, these patients tend to be right. It's not a cool thing. It's not a trend. It's something that is very real and needs a lot more attention. So because I'm double-edged sword and I'm in the community as a patient and also on the outskirts as a researcher, I kind of see what's going on in the community and hearing about these kinds of things. So I hope that changes soon, but and that's why it's good to do this research, particularly in New Zealand. So I thought for a while, we seem to be the first POTS research group in New Zealand. I'm not familiar with any other projects going on specifically looking at POTS. I thought for a while that I might need to go overseas to do this kind of research, but with the support of my research team at the University of Auckland and also the support of the Auckland Medical Research Foundation, who are funding my PhD, we've been able to bring this research to New Zealand, which benefits our New Zealand POTS patients.
Yeah, I guess we could talk about maybe what things are changing, if any, for the better. What are you seeing in terms of positive change, perhaps that's come from research or perhaps that's come from the community?
I think just along the lines of the recent stuff, just down the road is developing a lot of in the weight loss programs, but we found that because they've had their results validated by Massey University, and that sort of program helps us specific to be able to do things together as a group. So having these sort of weight loss programs that was community, where we have churches, where we community groups together, we found a lot more knowledge and diabetes numbers. Especially on our pre-diabetics, because a lot of they're going to be in that side of getting diabetes if it's done. So having them involved, so you can not only stop them from getting it, but just doing it together as a fun.
Yes, I was just thinking that we're often thinking about barriers, but we should also be thinking of good examples of where we've seen change and think about how that change came about, whether it can be learned, whether lessons can be learned. You must see that from the Neurological Foundation point of view, I guess, more, as you see the research come through.
Yeah, and I think like one of the barriers often with neurological conditions is kind of invisible for many people, especially in the early stages. And so the social acceptance can become a real barrier because there's something going on that concussion doesn't show up as an injury, it shows up as some strange behaviours. And so there's a lot of work that potentially needs to be done to help raise awareness of neurological conditions and make it more socially acceptable for them to talk about them and to have people understand them. And you were talking earlier around some of the research around mental health and how that's suddenly become more public and people are more understanding that there are issues going on. And I guess in the neurospace, one of the things that we can do to start making it more aware and more people more comfortable with those things. I mean, understanding how that best can support some of the conditions.
Outside of MND, a lot of previous work that I've done has used research to get policy change. We redesigned the GAP program done in pharmacies in South Auckland when I was at Manukau a few years ago. And I did the evaluation of that, and we've just got allopurinol, a recommendation to have available without prescription. With that work that we have done, really informing the model of supply and informing the medicines classification committee. So that's going to make a really big difference to continuation supply for people. So collaborative involvement with the doctor, but reducing some barriers to access for those patients. Qualitative and quantitative data were really helpful. And I've done previous work around vaccinations in pharmacy that's led to funding of that in pharmacy for pertussis vaccines for pregnant women, for example, and HPV vaccines. And so research can absolutely change policy and can change access and identify barriers to access. And I think for me, the research that I've been involved in has almost always had that, how does this create change, or how does this inform so that we can do things differently ahead or work out if this model is useful. I see that that's kind of my only interest in research, is not for the best citations, the big citations I can get, but how it can change things. And I think, community involvement will help that.
Natalie, on that, when you did that and advocated for policy change, did you have to prove financial savings in order to make policy change happen eventually?
Okay, so I'll talk about two different ones I just mentioned. So with gout, there's no financial aspect to the reclassification that makes it available through the pharmacy. So that isn't, cost considerations are not part of that. So that's simply, can we open up the barriers? But I am having discussions with Plunket because we do need to reduce the cost for patients. And that's a separate one where I do say, well, this is the likely cost of this. With the vaccinations in pharmacy, that one was interesting because there'd already been a decision made by Pharmac to fund the pertussis vaccine in pregnant people. And so extending it to pharmacy, there was the cost was going to be the same as if it was delivered in general practice, but it may get increased uptake. So we didn't need to do a cost benefit. We just what we needed to show was what we did, that it increased the uptake in Māori, which was really important because they have a lower rate than they should. Well, not should, but they have a lower rate than the rest of the population of uptake of pertussis vaccine, and yet they're at risk of having that in babies. So that was really important. And that then influenced also, they then could say, okay, well, if it's improving access for Māori for pertussis vaccine and pregnancy, then HPV has a slightly younger age, but they didn't need extra research done because that was enough to convince them that it was a good idea to do that as well. So the argument has already been made that this vaccination should be funded because it's cost effective to do so, and it's the right thing to do for the population. It's just about, it took years, I have to say, of pushing and data to get what we got with it being made for pharmacy, but for the better, for all the better for the consumer.
So another question on that. What if it took years? What was the main barrier then to move it from
bureaucracy? It was ridiculous, it really was. I put forward the argument in 2020, and I had academics help. So I had Cameron Grant, head of paediatrics at Auckland University, he was on there. Helen Harris was on there. Felicity Dumble, who was head of the Public Doctors Organisation at the time. So we had, arguments to say that this should happen, and then we did meetings and disseminating the results and everything else, and then finally it got over the line. But it should not, when you've got something that's actually really sensible and where it's really sensible, where we've got evidence, it should be a no-brainer, and there was no extra cost. It's not like there was going to be a whole heap of pregnant people out there suddenly coming up that weren't already eligible, so we're just getting it. So it's hugely frustrating, but if you've got evidence, it makes it easier to argue. You just have to be perseverance and resilience and open-mindedness. All of which I hope will help me at NED New Zealand.
Thank you.
Thank you, everybody.
Yes, thank you, everyone. Thank you all for coming along today. Thank you, Dr Anae, Rich, Greer, and Natalie for a fantastic panel discussion. What I took from this is that access to care a really big issue, and also awareness by clinicians of the conditions that especially the rare and poorly understood conditions. Understanding the lived experience is important too. And you all seem really keen on research. And I like what you mentioned, Dr. Anae, about partnerships being a good approach. And I don't know if it's necessarily the case across the board, but also was mentioned about early involvement being better, although it will take late involvement is a really good idea. And the last thing, Natalie, you mentioned is sort of research for policy change. And I'm glad you were grilled on that a little bit about how long it sometimes takes to get the policy change. But having that in your mind to start with, I think, was a really good way to shape things, which isn't always the case, I think, for researchers necessarily. So thank you very, very much for that discussion.